Let us now start with the discussion of the blood cancers, that is leukemias, under which we will have two, that is ALL and AML. Before we begin, a basic introduction of difference between a leukemia versus a lymphoma. Whenever we say that there is a cancer in the blood cells, we are talking about leukemias. And if I change that into cancer of the lymph node cells, then that would be known as a lymphoma. So I think the names are pretty much self-explanatory. Lymphoma would obviously be a cancer of the lymph node cells, and leukemia will be a cancer of the blood cells. But can they convert into each other? So if I say that this is a blood vessel and these are all the tumor cells or cancer cells which are here, so I would call this a leukemia because it's in the blood. Now, while traveling in the blood, if they decide one day to go and sit in the lymph node, so these cancer cells have now come while traveling, they have come into the lymph node. So can I say the leukemia has now changed into a lymphoma? Yes, it is interchangeable. It just depends on the site. Similarly, if there is a cancer in the lymph node, let's assume this green color is the cancer which is there in the lymph node, which is a lymphoma. One fine day, these cells decide that we are going to go and spill over into the blood. So can I say that the lymphoma has changed into a leukemia? So yes, I would put a two-way arrow between both of them. Leukemia can travel into a lymph node and become lymphoma. Lymphoma can travel into the blood and become a leukemia. This video is about discussion of leukemias. Let's start with the basic classification. We all know we have acute leukemia and chronic leukemia, but that's not based on acute and chronic like we study in English. Acute and chronic here refers to the blast count that we are dealing with. Blasts are immature cells of the bone marrow. So if the blast count is more than 20%, it is an acute leukemia, and if it is less than 20%, it is a chronic leukemia. Under acute leukemias, obviously we have ALL and AML, and under chronic leukemias, we have CLL and CML. Let's get used to their full forms. ALL stands for acute lymphoblastic leukemia. You need to understand for why have I used the word lymphoblastic here, because it's an acute leukemia and the blast count will be more than 20%. On the other hand, CLL is known as chronic lymphocytic leukemia. Why is CLL not called as chronic lymphoblastic like ALL? Because chronic leukemia doesn't have any blasts. That is why I will use the word chronic lymphocytic leukemia. This is where students make a mistake. So ALL is acute lymphoblastic leukemia. CLL is chronic lymphocytic leukemia. Talking about the myeloid lineage, under acute we have acute myeloid leukemia, and under chronic myeloid leukemia. So these words are simple. If I ask you which is the most common one that is found in children and the most common one in Down syndrome, that is going to be ALL. In children as well as Down syndrome, ALL. But which is the most common in elderly, and that is going to be CLL. So let's study them one by one, starting off with, of course, this category of acute leukemias for this video, and these are the two that we would study. Of course, when I say acute leukemia, you would ask me the blast count, which I've told you. So whenever I say that the blast count is more than 20%, that is a cutoff that has been given by the World Health Organization. But where are these blasts present? So when I say more than 20%, there could be more than 20% blasts either in the bone marrow or in the peripheral blood or both. So even if in one place I get more than 20% blasts, it is a clear-cut case of acute leukemia. But that is what World Health Organization says. There is another group which is known as FAB. It is French, American and British. So all the scientists and pathologists come together and have a meeting. French, American, British classification says more than 30%. So what am I supposed to follow? We always follow the WHO group for leukemia and hematology. So WHO says more than 20% blasts are going to be a case of acute leukemia. We have a very interesting term known as aleukemic leukemia. Right now you told me the blasts could be present in the bone marrow also. The blasts could be present in the peripheral blood, and in most of the patients of cancer, they are present in both places. What is aleukemic leukemia? This is a condition. See, when I use the word leukemia, this is certain that there is an acute leukemia. The blast count is more than 20%. So I will see that all the blasts are more than 20%, but they are sitting only in the bone marrow. They are sitting in the bone marrow. They are not ready to come out. When I took a blood sample from the patient, I did not find any blasts. So you are having a patient who has all the clinical features of a leukemia. But when you did a blood test, you did not find any blasts and you thought this is not a leukemia. This is something else. When you did a bone marrow, you saw all the blasts were hiding there. So can I say that this is a leukemia because blast count is more than 20%, but aleukemic means that are they coming out into the blood? They are not. Hence, this is known as aleukemic leukemia. So let us get going with the two acute leukemias. Like I said, the first one is going to be acute lymphoblastic leukemia, which is more common in children and most common in Down syndrome. I hope you remember this question from genetics, that the most common in Down syndrome overall overall means when the age of the patient is not mentioned, that is ALL. But if the age of the patient is mentioned in Downs and the child is less than 3 years of age, then the most common leukemia was AML M7. So overall asked, answer is ALL in Downs. Less than 3 years asked, answer is AML M7. So what is this acute lymphoblastic leukemia? Which are the two organizations we have? We have a French-American British organization and we have a WHO World Health Organization. Let's do both the classifications. For ALL, the French-American British classification says that ALL is divided into ALL L1, L2, L3. How simple. So these are the three pictures that I have got for you. If you look very carefully in ALL L1, look at the size of the blasts. All of them are going to have the same size. They look the same. So you have small homogeneous blasts. They are looking all the same. When I go to ALL L2, some blasts are going to be looking small, some are looking medium, and some are looking large. Overall, I can say there is some small population, there is some large population. So there are two populations seen. Hence, I call them heterogeneous blasts. Can I learn? In L1, they are all one size, homogeneous. In L2, they are all two sizes, small and large. So they are heterogeneous. In L3, it's even more interesting because I see blasts which have white holes in them, which means if, for example, this is a blast, can you see the white color vacuolation? There's a beautiful one over here with white color vacuolation. So what is the meaning of these white holes? These vacuolations contain fat, and we know fat is oil red O positive. So the question for ALL L3 is which is the only leukemia that can show you oil red positivity of fat deposition, that is ALL L3. Out of these, remember, God has made ALL L1 as the most common, and because it is most common, God wanted every patient to recover, so this has a very good prognosis. ALL L3 on the other hand is very rarely seen and it has a very bad prognosis. So thank God doesn't make it very common because the prognosis is pretty bad. There's another update now which says that if this is ALL L3, this is a blood cancer. If a similar copy-paste vacuolation situation occurs in a lymph node, ma'am, you said till the time cancer is in the blood, you will call it leukemia. So you're saying ALL L3. So these pictures of ALL L3. If you give me this picture and you say, no, this is from a lymph node, then I will call it a lymphoma. And that lymphoma will be Burkitt's lymphoma. So the latest updates say that the picture of ALL L3, the one with this vacuolation, and the picture of Burkitt's lymphoma is very similar. So maybe they have something in commonality with regard to their pathogenesis, but all this is being studied right now. So this is the FAB classification. In fact, when I zoomed in further, in some cases, in all of these, I could sometimes see that some of the blasts were showing this kind of a morphology as if you were holding a mirror. And that is known as the hand mirror shaped blasts. That could be seen in any ALL, L1, L2, L3, but it's seen. Whenever they use the word hand mirror shaped blasts are seen, you will always say that, oh, that is something that is to do with ALL. Now this was about FAB classification. Let's come to the real deal, the one that we follow. World Health Organization classification says no numbers L1, L2, L3 doing. We have two types of ALL, that is B lineage ALL and T lineage, which is common sense. This will show you B lymphoblasts and this will show you T lymphoblasts. B lymphoblasts or B ALL occurs in bachas. That is how we learn it. So this is going to be seen in children, whereas T ALL is going to be T, that is going to be seen in teenage. So B ALL bacha children, T ALL is going to be seen in teenage. This is a blood cancer. So all the cancer cells will be in the blood. Common sense. Can they travel? See, blood is going everywhere in the body. Can they go in some tissue? Which ALL do you think will show you tissue infiltration will be the T ALL? Which tissues? Let's go from top, middle, down. Top, it can go into the brain. Middle, it can go into the mediastinum. And down in boys, it can go into the testes. I'm not talking about girls. This more commonly involves the gonads of the boys. So top, middle, bottom. Top CNS, middle mediastinum, down testes. T ALL occurs in teenagers and shows you tissue infiltration. What about the genetics, which is a little tough? Please note, T ALL is going to show you T, that is notch gene mutation, whereas B ALL is going to show you the loss of PAX5, which is the most common mutation seen in B ALL. Also, it can show you mutation in gene, that is E2A and EBF. You don't learn E2A, EBF, I'm good to go. It's not going to bother me much. But you have to learn loss of PAX5. The reason being, I'll tell you a PYQ over here. What does normal PAX gene in you and me do? PAX5 gene is the needed one for B cell development. So today, if you're sitting fit and fine and your B cells are working good in your body, means your PAX5 has done a good job. These people, their PAX5 stops doing a good job. This means their B cells cells will not develop. They will remain immature. They will never mature. They will never develop. If they will remain immature, can I say they will form B lymphoblasts? And that is what happens. This is the WHO classification that follows. Now, overall, if they ask you that tell me all the genetics involved in ALL, and while telling me that, also tell me which are the ones with a good prognosis and bad prognosis. So the most common genetic abnormality in ALL is going to be hyperdiploidy. Diploidy means 2n, someone having 46 chromosomes. Hyperdiploidy means more than 2n, like triploid, tetraploid, and so on. Other than that, there can be trisomies. Trisomy 4, 7, 10. How I've learned it is trisomy means 3 chromosomes. Of chromosome number 4, if I add a 3, I get 7. If I add a 3, I get 10. Next, I have translocation 1, 2, 2, 1. If I add 1 plus 2, it is 3. If I add 2 plus 1, it is 3. Reason why I'm telling you this mathematics is that all these things which had something to do with 3 in ALL carry a good prognosis. Hyperdiploidy, more than 2 is 3, so good prognosis. Trisomies, 3 chromosomes, good prognosis. 4 plus 3, 7, 7 plus 3, 10, good prognosis. Translocation 1, 2, 2, 1, add them 3, 2, 1, add them 3. So all these 3 things will have good prognosis. On the other hand, if I say hypodiploidy, having less than 46 chromosomes, bad prognosis. MLL1 gene mutation, bad prognosis. Translocation 922, bad prognosis. So I think now learning the good and bad is easy, but now hang on. Translocation 922, are you telling it to me for ALL, ma'am? Because if I've read a little bit of hemat earlier, I know translocation 922 is Philadelphia chromosome for CML. So what is the story of translocation 922? Whenever chromosome 9 and 22 have a translocation, the two genes that fuse are known as BCR-ABL genes. Okay, they will fuse, and when students read this, they mark blindly CML, and you will not do that going forward, because now whenever these two genes will fuse, you have to measure what is the weight of the product formed. When they fuse, they can result in 3 different weights. Either it can be 190 kilodalton, if you add a 20 to it, 210 kilodalton, add another 20 to it, 230 kilodalton. 3 weights of this fusion protein are possible: 190, 210 and 230. Depending on the weight, I will have the type of leukemia that is occurring. For 190 kilodalton weight of BCR-ABL fusion, we will have ALL, which is acute lymphoblastic leukemia. For 210, it is going to be CML, and for 230, it is going to be CNL. And for those who don't know, it is chronic neutrophilic leukemia. I mean, that's going to be a tough task to learn in the exam. So an easier way is that you write 190, 210, 230. You can easily write this at intervals of 20, and then can you write alphabetically LMN. LMN will tell you that the first one was ALL, the second one was CML, and the third one was CNL. ALL, CML and CNL. But what's the patient? Like, patient really doesn't bother much about this weight that is formed. Patient bothers what kind of a disease have I got and how much will I survive. So now whenever BCR and ABL fuse, you know what happens and which enzyme activity increases in the body? It is increase in tyrosine kinase activity, which causes one of these leukemia. So prognostically what we see is that whenever there is a lower weight, like over here you're seeing a lesser weight, the tyrosine kinase activity will be more. So it works opposite. Lesser the weight, more is going to be the activity of the enzyme, and more the weight, less is going to be the activity of the enzyme. So one thing common sense I know, as I'll keep increasing the enzyme activity, the patient is going to have a problem. It's going to be bad for the patient. So can I say that in ALL, because the weight is very less, can I say that the weight is very less, so the tyrosine kinase activity is very more, and this seems pretty sad for the patient. So prognostically, translocation 922 for ALL is going to be very bad, and hence I've written it. All said and done, pathology done, how does my patient present? Whenever I say I have a blood cancer, means only it's like a hijack system. Cancer cells have taken over everything. Lymphoblasts are everywhere. So all the other cells have been suppressed. What are the 3 cells in the bone marrow? RBC, WBC, platelet. All of them will be suppressed. So if the RBC production is suppressed, obviously patient will have anemia. Anemia means patient will say, I'm always feeling very tired. There is a lot of fatigue. And when you look at the patient, she or he will be very pale. The child will have pallor, so anemia. Second, if the WBC count going down, and you'll be like, ma'am, what is that? This is a blood cancer. The WBC count should shoot up. Yes, but in that WBC count, it is only blasts which are shooting up. What about the other WBCs like neutrophils, monocytes? All of them are not getting chance to grow, and hence the patient will land up with infections. Similarly, when platelet will not be allowed to get formed, patient will have bleeding. So kids come to you with fatigue, pallor, infection and bleeding. The same blood cancer can start going to organs, like it goes into the liver and the spleen. The child will have HSM, hepatosplenomegaly. Then I told you tissue infiltration is possible by which ALL? That is TALL. Whenever this kind of a situation comes, the first thing you will do is a blood and a bone marrow analysis. And we have always told you that in the blood and the bone marrow, you will see equal to more than how many lymphoblasts? 20% at least. And do you know special stain for lymphoblasts that I've already taught you? Lymphoblasts are pass positive. P for pass, P for pink. They show you the dot, blot or block positivity. But when you want to select T lymphoblast, it will be positive for acid phosphatase. All of this I have taught you in the first part of this video. However, what is the diagnosis of choice? For most of the leukemias, diagnosis of choice is flow cytometry. This is a machine which measures CD markers, because by measuring the CD markers, I will easily be able to tell you that whether you are dealing with a BALL or you are dealing with a TALL, because there are different CD markers for B and T that we have to know. Finally, we have done with everything, and now the last table of ALL is something like a formality which you will fill up for me. What are the prognostic factors for ALL in terms of being good and bad? Please note that whenever you get a 2 to 10-year-old girl, that is good. 2 to 10-year-old girl child is a good prognosis, whereas anything above this or beyond this means a less than 1-year-old or more than 10-year-old. So 2 to 10 is good, less than this and more than that, and also a boy is bad. Why is being a boy considered as a bad prognosis in ALL? Because I told you that testicular involvement can occur in TALL, so that is why boys have a bad prognosis. Similarly, in terms of ethnicity, blacks are going to have a worse prognosis. Talking about the FAB classification, I think I already told you that L1 is going to be the good prognosis and it's more common also. L3 is going to be the bad prognosis and is the less common one also. Under WHO, BALL, TALL, which one do you think is going to be bad? Put your common sense into it. The one that is going in tissues like the brain, mediastinum, testes, of course that is going to be horrible. So TALL is going to be bad and BALL is going to be good. Then genetics I've already taught you. Everything with 333 was good. So this means hyperdiploidy more than 2n, all trisomies and translocation 1-2-1 is going to be good. Everything other than that, like hypodiploidy, BCR-ABL 922 and MLL1 gene mutation is going to be bad prognosis. So ALL, that is acute leukemia, lymphoblastic leukemia is done, and we can move on to AML, where the story is that now the blasts have changed. See, till the time it's an acute leukemia, the count will be equal to more than 20%, but now it's not the lymphoblasts, now it's the myeloid lineage. For this also, we are going to follow a similar pattern of first having a FAB classification and then a WHO classification and finally the prognosis, exactly how we read it over here. First, let me start with, as usual, the FAB classification, because here the main deal that we are following is FAB actually. Everywhere else we follow WHO, but in AML even today we follow FAB classification, which says AML goes from M0 to M7. For ALL, if you remember, it was L1, L2, L3 and life was sorted. For AML, it is M0 to M7, which is going to take 15 minutes of your life. So be very attentive. Learning their names. No, you can't learn them as M1, M2, M3, and it's not going to be that simple. You will have to learn their names. So starting with AML, M0 is known as AML undifferentiated. Now, how I have learned it is undifferentiated means that, ma'am, it is not looking like an AML only. It is an AML, but a regular pathologist will not be able to guess this. Why? Because when I say myeloid blasts, myeloblasts, the first marker and stain that I told you was myeloperoxidase. But they are so primitive and so undifferentiated in this category that even myeloperoxidase is coming out to be negative. And hence people get confused that is this even an AML? How I have learned it and everyone else along with me learns it. M0 looks like ANDA. So ANDA is 0, undifferentiated. Then coming to AML M1 and M2. M2. M1 is AML without maturation. M2 is AML with maturation. How did I learn it? M1 looks like younger brother and M2 bigger number, so elder brother. Younger brother will not have any maturity, elder brother will have maturity. But what does it mean technically is that this is the blast category in which mostly blasts will be seen. Will you see the blasts maturing into future cells? No. Whereas in M2, will you see the blasts maturing into future cells? Yes. So AML without maturation, AML with maturation. AML M2 is the leukemia overall in the 0 to 7. The most common AML is AML M2 and it shows you translocation 821. Now, whenever 821, see, translocation means that two genes are going to fuse. So this is going to show you RUNX1 and RUNX1T1 fusion. RUNX1 and RUNX1T1 fusion is going to be noted in cases of AML M2, the most common one. Now coming to AML M3, it's got so many things. Don't read them together. First, just know the name with me. AML M3 is going to be acute promyelocytic leukemia. Ma'am, over here you have not used the word AML, you have used the word APML. So over here whenever you were using AML, we meant myeloid, myeloblast, myeloblast, myeloblast. But when you started using APML, means rather than myeloblasts, the preponderance or the dominance of promyelocyte will be seen. What does that mean? So whatever I taught you in the first video, I have written it again. Do you remember the first cell is myeloblast, which has OR rods? Then you have the promyelocyte, which is the largest cell in the series. Then you cut the pro, so myelocyte, then you add a meta, so metamyelocyte, then a band form, and then the neutrophil, basophil, eosinophil form. Do you know, for this entire thing to occur, it is very important that there are two genes which work. Most important out of them is going to be RARA. You don't have to know the full form of RARA, but writing it will really give you a lot of clarity in your concept. Retinoic acid receptor alpha, which means that, ma'am, retinoic acid is vitamin A. So, okay, do I need vitamin A so that this entire process can go on? In simple words, yes. But now what happens in AML M3 patients, what you're calling as AML M3, there is going to be translocation 15-17, because of which PML and RARA gene fused. This retinoic acid has gone and fused with something else. As a result of which, will this process occur now? No, it won't. And where will it go and stop? It will put a stop over here. Now you understand, myeloblast will form promyelocyte, but after that, will it form anything else? No. So which is the cell which will keep on increasing? Lots and lots of promyelocytes will keep on increasing. Hence, I call it acute promyelocytic leukemia. And if I want to treat this patient, if I have a block over here, ma'am, and you remove the block, why do you want to treat it with chemotherapy? Like you treat every other cancer with chemotherapy. You don't treat this one with chemotherapy, because here you know the problem is in this retinoic acid. The day I can give retinoic acid, the maturation will start and I don't need unnecessary chemotherapy for this patient. So that is what I give in the treatment. I actually give a metabolite of vitamin A, ATRA, all trans retinoic acid is given for the treatment. Treatment of AML M3 is ATRA, and along with that I give arsenic trioxide. So that is exactly what I've written. APML shows you translocation 15-17, that is PML RARA fusion, and for the treatment you are going to give ATRA as well as arsenic trioxide. But this is all medicine part. Treatment and all. What do you see in pathology? In pathology, we see something called as faggot cells and phi bodies. What is that? So I will zoom into every cell. Usually what you've read is these, what are these pink color rods? They are known as OR rods. This could be a myeloblast. Okay. In the next, I saw that they are not one. There are many. There's an entire bunch of OR rods. Too many. In the next one, I saw there are OR rods and they are trying to cross each other. So when OR rods are crossing each other like this, crisscrossing OR rods are known as faggot cells. Sometimes instead of OR rods crossing like this, they might try and make this triangle kind of a body. So that will be referred to as a phi body. They will not give you a picture, but it means the same. Whether you see this triangle kind of a body called phi body, or you see these crisscross OR rods called faggot cells, they all mean that this is a case of AML M3. But why is it forming, ma'am? Because all of these dot 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 which are making rods and which are making triangles, these contain granules. Those granules have come together, and something very interesting which you need to look out for now. These granules contain procoagulant material. Procoagulant material means they can cause coagulation. They can cause clot formation. Do you ever want them to come out of the cell and cause clot formation in you? Not at all. So by chance, if someone was not aware and someone ended up giving chemotherapy, what is the basic principle of chemotherapy? That the cancer cells die. There is going to be cancer cell death, and you are thinking that, oh, the cancer cells are dying, that's so good. But as soon as the cancer cells will die, what is going to be released? The granules are going to be released, and as soon as the granules release, they will release all their procoagulant material. Patient will land up with a lot of clots, which means patient will land up with DIC. So do you want to give chemotherapy in this patient? Do you want to release all these granules and all these procoagulant material and cause DIC? Of course not. So they ask you, which is the leukemia showing faggot cells and fibroids? AML-M3. Which is the leukemia associated with DIC? AML-M3. And now you know why we don't give chemotherapy. By giving chemotherapy, you wanted to give it for treatment. Patient might end up dying because he would land up in DIC. So for the treatment, you are going to give atra and arsenic trioxide. That's the entire story of AML-M3. The recap till now is AML-M0 is undifferentiated, M1 without maturation, M2 with maturation, M3 is going to be APML, and now I go to M4 and M5. M4 is known as AMML. AMML means it is acute myelomonocytic leukemia. The name is enough. Myelo will tell me that it will have myeloblasts, and mono will tell me that it is going to have monoblasts. Why does this occur? This occurs because of an inversion in chromosome 16. So one part of chromosome 16 just took a flip and got inverted. That's it. Whenever there is an inversion, this location, like for example, if you are facing right now, sitting while facing the wall, if I just tell you to flip and now you're facing the other side of the room, obviously there's going to be a change, right? First your books were kept on this table. If you just flip, now obviously your back will be towards your book. So you can't flip. Similarly, for chromosome flips, all the genes will also change their place. There is going to be a fusion of CBF and MYH. If you want to know the full form, CBF is going to stand for core binding factor. CBF, core binding factor, and MYH fusion is going to occur. How I have learnt it always is that this is following a simple mathematics. So for example, how many blasts does this have? Ma'am, it has two blasts. Myeloblast also, monoblast also. So it is myelomonocytic leukemia. 2 ka square, when you have two blasts, which AML are you talking about? AML M4. And AML M4, 4 square is what? 16. So this is going to show you inversion 16. So when you see 2 blasts, that is AML M4, and that is 4 4s are 16, inversion 16. And this is so much of maths. Maths is the core of everything that we study, right, from our school days, right? Not for medicos, but for everyone else. So that's the core of every subject. So core binding factor gene is involved. Now coming to AML M5, what I would want is that earlier you had 2 blasts and now you remove the myelo because now you only want to keep the monoblast. So that is why M5 is known as acute monoblastic leukemia. It will only and only have monoblasts. Do you know what is the purpose of teaching you so much about monoblast? Because wherever monoblast will come, tissue infiltration has started. This means AML M4 and AML M5 are going to cause tissue infiltration. Like for example, they enter into the gums, and that is why people have gum hypertrophy. They enter into the skin. That is why leukemia going into skin is known as leukemia cutis. So which leukemias can show you tissue infiltration? AML, M4, M5. If you ever have to select one, it is always going to be M5. And it goes into so many tissues. That is why AML M5 can cause chloroma. So what is chloroma is the next question. Ma'am, it is something to do with tissues is what I have understood, and that is exactly what we will study in a while. To be very precise, it goes into the orbit. For the time being, this is enough. Coming to AML M6, this is to do with RBC lineage. This is pure erythroid leukemia. And AML M7, the one you used to see in Down syndrome babies, that is known as acute megakaryoblast leukemia. And now I'm going to tell you a logic or a concept which I personally loved it when I reached this end of this and I first time got to know it. Whenever I was saying previous leukemia, that is ALL, you were calling it acute lymphoblastic leukemia because ma'am, you were seeing lymphoblasts. Okay, but ever since you started discussing AML, you did not call it acute myeloblastic leukemia. No, you called it acute myeloid leukemia. Why didn't you call it myeloblastic? Because I realized that the starting few ones were showing me myeloblasts. Okay, but then M3 started showing me promyelocytes. Then M4 and M5 started also showing me monoblasts. Then M6 started showing me RBC lineage also, and M7 started showing me megakaryoblast lineage also. So there are multiple blasts involved over here, not just myeloblasts. And hence, rather than calling it acute myeloblastic leukemia, we call it acute myeloid leukemia. Out of these, AML M7 is otherwise the least common. If you see in a general population, least common. But if you see in Down syndrome babies less than 3 years of age, this is the most common to occur. Which category? The last one. So which translocation? I take the first and the last chromosome. Translocation 1, translocation 22. 23 is last, but that's sex chromosome, so I ignore that. For the last AML, I take first and last chromosome, translocation 122, and this leukemia causes fibrosis of the bone marrow. So if this is the bone marrow that I've drawn over here, there is going to be a lot of fibrotic tissue, which means that if I try to do a bone marrow aspirate, if I try to put a needle, will I be able to withdraw cells out of it? No, because they're all entrapped in that fibrosis like a cage. So these are all the things regarding AML that you had to study. Because there is a mention of Downs, I want you to revise 3 questions from genetics chapter. Which is the most common leukemia overall? Overall it was ALL. But if you are asked in Downs less than 3 years of age, then the answer becomes AML M7. But I hope you've not forgotten what I taught you in genetics, which is the most common hematological abnormality in Down syndrome. See, whenever I say most common hemat, you think it is going to be a blood cancer. No, hemat abnormality can be anything. From a blood cancer to an anemia to a platelet problem, hemat just means blood. So the most common blood abnormality in a patient of Downs is not leukemia, it is TAM. It is transient abnormal myelopoiesis. Means what? Transient means it lasts only 5-6 months. Abnormal which cells? Abnormal WBCs, a myeloid lineage. Abnormal WBCs are going to be formed in the blood, but they are formed for a very short duration. They are formed for only a few months, and that is why we call it transient abnormal myelopoiesis. So whenever someone asks you most common hematological abnormality, don't start jumping to leukemias directly. Finally, you're done with the FAB classification that went for AMLs M0 to M7, but that doesn't wrap up because the WHO classification is still remaining, and that has 4-5 categories. The first one is roughly what you know, and that is AML with recurrent genetic abnormalities. Ma'am, I just read that. In a way, I read it as M1, M2, M3, but now they've just taken all those words out and put the genetics in one place. So AML with recurrent genetic abnormalities, the first one that I read for M2 was translocation 821, showing you RUNX1, RUNX1T1 fusion. For AML M3, we studied translocation 1517, which is PML RARA fusion. For AML M4, we studied that there is going to be inversion 4/4/16, and that is core binding factor and MYH gene mutation or fusion. Then for AML M7, we studied the first and last, that is going to be translocation 122. So these I already know. Now let me add. There can also be an AML which is to do with translocation 6-9. There can be an AML with NPM. It is a kind of a protein called nucleophosmin, full form not read it, NPM mutation. And there is an AML with CEBPA mutation. I'm sorry, but you'll have to learn these slightly tough genes. So translocation 6-9, NPM mutation, CEBPA mutation are extra. Before I go on, where else have you studied translocation 6-9? This is important for INI-CT. Right now I told you it can be seen in AML. Second, I will teach you in the salivary gland chapter that there is a salivary gland tumor called adenoid cystic carcinoma that also shows you translocation 6-9. Do you know when AML occurs with translocation 6-9, there is a special elevation of a type of a cell which is known as basophil. So AML translocation 6-9 shows you elevation of basophil. Whereas AML with inversion 16, the one that is AML M4, I'll write it again over here, that is famous for showing you an increase in eosinophils. So much so that many people call it AML M4U. They've labeled it like that. So repeating, when inversion 16 occurs, eosinophils increase. When translocation 6-9 occurs, then basophils are going to increase. This is the first category, AML with recurrent genetic abnormalities. The second WHO category is AML therapy associated. WHO says that AML is a blood cancer that might occur because previously the patient had been exposed to some alkylating agent or topoisomerase inhibitors. Maybe previously the patient had some cancer, say a papillary primary carcinoma thyroid, or some other kind of a cancer or a lymphoma for which he or she had got treatment. 5-10 years later, because of those drugs, now the patient has ended up having AML, so that is therapy-related AML. Coming to the third category is AML with myelodysplasia. Did you read everything about other cancers in systemic pathology like cervical cancer, or I can say prostate cancer? It doesn't happen overnight. If a female has cervical cancer, then she must have had pre-cancer also, which you call as dysplasia. Same way, if someone has had a cancer that is AML, there must have been a pre-cancerous situation called dysplasia of the marrow, myelodysplasia. So AML, before AML, there must have been a pre-cancer called myelodysplasia. What does that mean? That at least 2 lineages are showing you pre-cancerous changes in more than 50% cells. In simple words, the 3 lineages of the bone marrow are RBC, WBC, platelet. Out of RBC, WBC, platelet, out of these 3, at least 2 lineages are showing you some problem, some weird bad looking cells, and those cells are at least more than 50%. So if you are counting 100 white blood cells, at least 50 white blood cells should show you the pre-cancer changes. If you are counting 100 RBC lineage cells, at least 50 cells should show you the changes. So dysplasia in more than 2 lineages and more than 50% cell is AML with myelodysplasia. The fourth one is AML NOS, not otherwise specified. That has everything. That is basically a copy paste of the classification of FAB. Everything about FAB has been put up over here except AML M3. The APML is not over here. Rest AML M0, 1, 2, 4, 5, 6, 7. Copy paste becomes, as per WHO, AML NOS. And lastly, AML associated with Down syndrome. WHO calls it a separate category. I know for all practical purposes, FAB had called it as AML M7. All of this is settled. Now I just want to tell you that there is a provisional category also that is coming up only for INICT students. It has not become a part of the main classification, and that is AML with mutation of RUNX1. I'm not saying RUNX1T1. I'm not saying the AML M2 wala. This is just RUNX1 gene mutation which is coming across as a provisional category. All the classifications are done. First I did the FAB classification from M0 to M7. Then I did the entire WHO classification and all the 5 stages. But in between, I had mentioned loosely one term called chloroma, and that I want to discuss. If you remember, I told you whenever AML is a blood cancer, the cancer cells should be in the blood. But if they end up going into the tissue, soft tissue, that is when I call it a chloroma. So can I say it is actually going to be a granulocytic. Granulocytic means a WBC disorder, but in the tissues, and hence I call it granulocytic sarcoma. Granulocytic sarcoma. The next, other name, chloroma. And another name, because chloroma is ultimately an AML only, I call it myeloblastoma. So all these are same name. Myeloblast, tumor, myeloblastoma, chloroma and granulocytic sarcoma. What is it, ma'am? It is actually a blood cancer, but it is occurring in the soft tissue. So which is the most common site? Usually it occurs in the orbit. So if this is the eyeball and behind this I say there is a cancer occurring, obviously the eyeball will be pushed forward and the patient will land up with proptosis. Now comes the tough part, the one that is toughest to learn. What are the markers of chloroma? Before that, which is the AML that can go into soft tissues? Ma'am, you had told us AML M5 goes into soft tissues. So yes, M5 is the one that causes chloroma. Can M2 also cause chloroma? Yes. So answer is M2 and M5. Anything that goes into soft tissue, M2 and M5 can cause chloroma. What are the markers? The tough part. This is a myeloid lineage tumor. So myeloperoxidase has to be present. Along with that, CD43, 45, close, and lysozyme positive. Repeating, myeloperoxidase and lysozyme, these are the enzymes. CD43 and 45 are the CD markers. Talking about the cells, it's a myeloblast, AML hai, so I will see lots and lots of myeloblasts, no doubt about it. No one will ask you this. What other cells are seen? Sometimes, see, the main problem is a myeloblast tumor, so I will see myeloblasts. But along with that, you also see Arbiskov cells. Arbiskov cells are not myeloblasts. Arbiskov cells are a reactionary change in the monocytes. Because the monocytes see that myeloblasts have a problem, let me also start looking a little weird. Atypical monocytes are known as the Arbiskov cells. So this is all said and done, and now you're ready for the diagnosis, all of which you know. For the diagnosis, what should the blast count be? It should be equal to more than 20%, which we already know. What is the diagnosis of choice? For every leukemia, it is flow cytometry, because it is going to tell you all about the CD markers and it will tell you everything about myeloid, monocytic, megakaryocytic, all lineages. But The diagnosis of choice for AML M3. What was AML M3? APML. Ma'am, for that CD markers will not help. If you want to make the diagnosis of AML M3, please prove translocation 1517, which is the PML RARA fusion, and any translocation will be proved with the help of FISH. So till now I have studied diagnosis of choice for ALL was flow cytometry. Diagnosis of choice for all the AMLs is also flow cytometry, but diagnosis of choice for AML M3 is going to be FISH. Every time I do a new leukemia, I will make the diagnosis of choice list again. Finally, you are done with all of this, but now comes INI-CET questions. Number 1, what are the special stains that can be used in the leukemias from AML M0 to M7? See, you've got 3 questions that usually when we see blast, we do flow cytometry and FISH and the diagnosis is done. But every center will not have flow cytometry and FISH. These are expensive. They might be taking use of some inexpensive economical methods like using stains. First, I'll remind you, do you remember what were the stains for myeloblast? Ma'am, of course, myeloperoxidase and chloroacetate esterase. Whereas for monoblast, we had learnt it as mononoblast. That is why it was non-specific esterase. Talking about PAS, periodic acid shift, we had always studied what is PAS doing over here. We had studied PAS was showing me block positivity in ALL, yes. But can it also show me some positivity in AML? That is correct, M3, 6 and 7. Which means that AML M3, AML M6 and AML M7 are also PAS positive. Now the PAS story becomes complete. ALL of course and AML M3, 6 and 7. Now next, do we agree AML M0 is ANDA? ANDA is not going to show you anything, so that is going to be even myeloperoxidase negative. Hence I call it undifferentiated. AML M1, M2, wherever you see myeloblast, ma'am, the story will be MPO and chloroacetate esterase. Okay. The question that is always asked is AML M4 and M5. Why? Because AML M4 is acute myelomonocytic leukemia. You see myeloblast also, you see monoblast also. So for the myeloblasts, you are having positivity of myeloperoxidase and chloroacetate esterase. For monoblast, you will have positivity of non-specific esterase. I will repeat it again. For myeloblast, you will say chloroacetate esterase, and for monoblast, you will say non-specific esterase. Are both the esterases coming positive? And that's the question that comes. Which is the only leukemia that shows you dual esterase positivity, and that is going to be the one that has both the blasts, that is AML M4. AML M4 is going to show you dual esterase positivity of chloroacetate esterase and non-specific esterase. Coming to AML M5, this only has monoblasts, acute monoblastic leukemia, so this will only be non-specific esterase. On the last day, when you want to quickly wrap up things, remember 2 questions. Which are the AMLs in which PAS is positive? Is AML M3, M6, M7, and which are the ones which showing dual esterase positivity, that is chloroacetate and non-specific esterase, is going to be AML M4. Talking in terms of prognosis, the translocations that you studied are all going to be the good prognosis. For example, I told you for AML M2, it was translocation 821. For AML M3, 1517. For AML M4 inversion 16. All of these are good prognosis. Another way of learning it is you have to go by multiples. For example, the multiple of 2. If you feel 2 was showing me 821 or was it showing me 1517? So think 2 will go with 8. So 821. 3 will go with 15. So 1517 and 4 4s are 16. All of them have a good prognosis. One more thing, another update. These AML, going back to the first line, what is the classification? What is the diagnostic definition of any acute leukemia, ma'am? When the blood count has a blast of more than 20%, you say acute leukemia. But if you prove any of these, translocation 821, translocation 1517, inversion 16. If you know, if you have a report in front of you, patient has any of these, then you're like, I am not looking at the blast count. Now the blast count is more than 20, less than 20, 0 also, that does not matter. If someone has proven genetic translocations, then the blast criteria becomes irrelevant. You will say it is AML. So let me give you an example. If someone has a blast count of 25%, anything more than than 20, would you want to call it, and I say myeloblast more than 20%, you will say, yeah ma'am, this is AML. If I say someone has a myeloblast count of 5%, do you want to say AML? No, because this is less than 20%. But if I say someone has translocation 821 and the blast count is 5%, you're like, ma'am, when you're seeing translocation 821 blast count, I don't care. It is always a case of AML. If you see any of these translocations, don't look at the blast count. It is a proven case of AML thereafter. Finally, you're done with all the acute leukemias, and a very quick recap: which subtype of AML is least likely associated with chloroma? I told you M5 and M2 are more commonly associated, so they are definitely there. Even M4 can sometimes go into the tissues. Remember, I told you M4, M5 goes into the tissue, so least likely is the one that causes DIC, that is AML M3. Coming to another question: which class of ALL, according to FAB classification, has cytoplasmic vacuolations, that is ALL L3, and that is going to have fat. Fat means it is oil red O positive. What is the expected mass of BCR-ABL fusion protein in case of ALL? So it could be 3, 190, 210 and 230 kilodalton, and we had learnt it as LMN. So for ALL, it is going to be 190 kilodalton, 210 kilodalton is seen in CML, and 230 kilodalton is seen in CNL. All the acute leukemias come to a halt for you. Done with this, revise this once before you jump on to chronic, because if you read everything in one go, it's going to create a confusion. So first, wrap up all your acute leukemias, do your Q bank, and then move on to the chronic leukemias.